This next case is the endovascular management of an anterior communicating artery aneurysm. This case is of a 50-year-old male who presented with a 4-day history of acute onset of the worst headache of his life. His past medical history was significant for hypertension and remission of lung cancer and a family history of subarachnoid hemorrhage. His neuroimaging demonstrated an anterior communicating artery aneurysm. As you can see from the three-dimensional reconstruction, the dome-to-neck ratio is favorable for coiling. It is incumbent upon the operator to get favorable views that separate the neck from the aneurysm as well as apparent vessels from the neck of the aneurysm. Here you can see we're coming up with the microwire and microcatheter. We need to avoid the large posterior communicating artery. One can see the wire with a significant curve getting into the A1 segment of the anterior cerebral artery. The microcatheter then follows. Once the microcatheter is in the A1 segment, one can consider catheterizing the aneurysm. As you withdraw the wire, the catheter often moves forward and will move forward into the aneurysm, and one has to be careful to keep the tip of the catheter away from the dome of the aneurysm when withdrawing the wire. Withdrawal of the wire should always be done under angiography, as the microcatheter will advance forward in some settings. Here we can see the catheter is close to the dome of the aneurysm, and one should let off pressure of the catheter or potentially consider pulling back the microcatheter as the coil comes out, as is demonstrated here. We use three-dimensional coils that are appropriately sized to the aneurysm in order to create good circumferential packing of the aneurysm. We then proceed with smaller three-dimensional coils, again, as previously stated, using the Russian doll technique. In smaller aneurysms, we like to keep the catheter near the neck of the aneurysm and coil from the neck. Occasionally, this will advance the entire coil mass forward, while creating stability at the neck and preventing coil herniation into the parent vessel, as is demonstrated here. Coiling from the neck is an important technique, especially in aneurysms that have a moderately sized neck or a moderate dome-to-neck ratio. It is important for the operator to constantly evaluate the coiling on multi-plane imaging, such as the lateral and the AP. Once there is sufficient coil packing or sufficient density of coil in the aneurysm, one should consider ending the coiling procedure. Here you can see on this projection that there is still a cavity in the aneurysm where it's possible to continue to fill with some residual coil. This angiogram shows that there is modest filling of the coil, while there is still some area of patency of the aneurysm. Often, this will thrombose. At this point, we withdraw the microcatheter by pushing on the coil pusher to prevent any herniation of coil. This is an exchange technique that we use with the coil pusher and the microcatheter. Here you can see sufficient coil packing of the aneurysm, which most oftentimes goes on to thrombose.